Thank you for joining me this evening. My name is Vicky. I am the Clinical Support Manager for BioMonde. And you'll have to forgive me. I normally have my colleague Rebecca with me, and I'm new to doing this on my own. So if you can be kind to me, look after me. So thank you for joining. As I said, my name is Vicky, and we're going to be doing a webinar today all about pressure ulcer management with larval therapy. It's a very special one because it's Stop the Pressure Day. Thank you for all commenting in the chat. I'd love to hear how your Stop the Pressure days have been. If you've done anything exciting for them, do let me know, and let everyone else know as well. Of course, if you are using the chat, don't forget to click everyone. Just a bit more housekeeping before we get started and before I tell you what we're going to be talking about today. As I said, this is our Stop the Pressure special. It's going to be roughly about 20 minutes. I will leave time at the end for a question and answer section, so do pop some questions in there. If you don't know where that is, do hover down the bottom of your screen. You should find a little Q&A speech bubble. If you click on that, you can put your questions in there, and I will get to them at the end. You won't be able to talk to me directly, so that's the best place to put any questions. And as I say, you've got the chat box as well, and do feel free to talk to each other. Share that you are here. We love to hear where you are, and you can, as you can see there, we've got our social media handles, so maybe go on there and tell everyone that you have come to watch this live today. So what are we going to be talking about today? Well, by the end of this special Stop the Pressure live, you will hopefully understand the structure and function of the skin. You'll understand how pressure ulcers occur and how they impact the integrity of the skin. You'll understand why debriding devitalized tissue in pressure ulcers is important, and you'll understand how larval therapy can be used to support the management of pressure ulcers. So rolling straight into it, let's start at looking at the skin and what it does. The skin, hair and nails form the largest organ in the body, and a lot of people do forget that it is an organ. It ranges in thickness throughout the entire body, so from around 1 to 1.5 millimeters at the sole of the feet to just about 0.5 millimeters at the eyelid, so very, very thin. And if it was laid out flat, it would average about a size roughly about 2 meters squared. Comprises of 3 layers. So we've got the epidermis on the outermost layer, then the dermis, and then the hypodermis, or you might hear it called the subcutaneous layer. The epidermis is the outermost layer, as I said, and it's made of about 4 to 5 layers in itself, depending on where it is in the body. It's comprised of almost entirely of keratinite cells, and these are the primary building block of the epidermis. And the layer is largely avascular, so it relies entirely on the dermis to provide it with nutrients and manage any waste. The prime function of the epidermis is to act as a physical and biological barrier to the external environment, preventing penetration by irritants and allergens, things like that. And at the same time, it's also preventing the loss of water and maintains internal homeostasis. It also contains cells called melanocytes, which are the cells which create our skin tone, Langerhans cells, which are part of the immune system, and Merkel cells, which play a role in sensation. Next up, you've got the dermis, which is the second layer below the epidermis. And this is much thicker than the epidermis, and it's broken down into just 2 layers. It contains the hair follicles, sweat glands, nerves, blood vessels, and its primary role is to sustain and support the epidermis. The main cell of the dermis is the fibroblast, which produces collagen and elastin, and collagen gives the skin its toughness and strength. It makes up about 70% of that dermal layer and is continually broken down and being replaced. Elastin, which is the other product I was telling you about, these elastin fibers give the skin elasticity, so it's nice and stretchy. At the bottom layer of the skin, as I said, is called the hypodermis or the subcutaneous layer, and contains connective tissue, and adipose tissue or fat tissue. It provides the main structural support for the skin, as well as insulating the body from cold and aiding shock absorbance. And it's interlaced with blood vessels and nerves and things like that. There's quite a lot going on in sometimes very small layers, such as your eyelid. The skin is very important, has lots of different roles, and it doesn't just protect our organs and stop them all falling out. The 3 layers of the skin work together to perform a range of functions, including protecting against infection, regulation of heat, sensation of pain, temperature and pressure, vitamin D production, excretion of sweat, waterproofing, and even communication. And as we age, the integrity of our skin and its healing abilities diminish. So by the time we get to the age of 60, our skin can typically be considered as vulnerable. And when something happens to the skin to impair it, such as pressure damage, in this case, it's no longer able to perform these functions at all sometimes, and in turn puts the patient at risk of harm. Prevention from pressure damage is the first and best option for maintaining skin integrity, but if damage does occur, it's really important to treat it in a timely manner to reduce the impact it has on the body. So let's have a little closer look at what pressure ulcers actually are. And here's a lovely picture of one for you to get the ball rolling. And here you can see the definitions of what pressure ulcers are according to the European Pressure Ulcer Advisory Panel. So a localized area of damage to the skin and or underlying tissue, usually over a bony prominence or related to a medical or other device, resulting from sustained pressure, including pressure associated with shear. So that's kind of those dragging forces. And the damage can present as intact skin or an open ulcer and may be painful. So it's only recently that this definition has been widely recognised, but in 2018 it was very recently adapted to include tissue damage caused by medical devices such as oxygen tubing or splints, and these are now recognised as pressure ulcers. And pressure ulcers can have a huge impact on both patients and healthcare services. So for the patient, quality of life can be significantly reduced, both temporarily and permanently, depending on the depth of damage. For deeper, full thickness damage, patients may require surgery. They can be left disfigured and with altered mobility permanently. Pressure ulcers can also be high risk of becoming infected and in turn put the patient at risk of sepsis. Both the pressure ulcer and treatment can be very painful for the patient, and it must be taken into consideration that pain is an issue for a patient even if they haven't fully verbalized it. Pressure ulcers also have a significant impact on clinical services and clinicians as well, with around 4% roughly of total budget for the NHS being spent on managing just these ulcers. Patients require frequent repositioning and dressing changes, as well as treatment to manage any other complications which come with pressure damage, such as pain or infection, and we know these don't come for free. And as a lot of you probably know, pressure ulcers are categorised according to the depth of damage that has occurred, according to an internationally agreed classification tool designed by the European Pressure Ulcer Advisory Panel, or EPUAP. And in 2019, this tool was revised, and as I mentioned already, now includes medical device related pressure ulcers. Pressure ulcers which occur on mucous membranes are not included in this grading system, as these particular injuries cannot be staged in the same way because the anatomy of the tissue is not the same as skin on other areas of the body. And particular care should be taken when assessing patients with darkly pigmented skin, as signs such as blanching erythema or discoloration from a deep tissue injury may be more difficult to observe. So in these cases, it's important to take into account any reports of pain, or if the skin and the underlying tissue feels indurated, i.e. it feels hard but not swollen, or maybe even more spongy. The skin may also feel more warm or more cool to touch than normal, depending on how advanced the pressure damage is. It is worth noting as well that when a pressure ulcer is healed, it should be referred to as a healed category, whatever it was. So a healed category 2, healed category 3, depending on what it was originally defined as the tissue that replaces that damaged area is not the same as the tissue that was originally damaged, if you see what I mean. So it doesn't have the strength or the elasticity that the skin originally had, and will always be high risk of breaking down again. And here you can see a good diagram of how pressure affects these different layers of the skin. The ulcers can occur on any bony prominence on the body, not just the sacrum and the heels, which we know are the most, or usually the most common areas. And as you can see, as pressure from a surface pushes against an area of the body, blood vessels are constricted, which in turn leads to cell death, and that in turn leads to breakdown of the tissue. And the longer those blood vessels are constricted, the more damage is caused to the underlying tissue, and the larger and deeper the resulting pressure ulcer can be. Now, the most important thing to remember is that with all pressure ulcers, they need to have the cause of pressure removed in order to resolve. So this means that at the very least, someone with pressure damage should be assisted to reposition themselves frequently, to allow that pressure to be offloaded, whilst taking care, of course, not to allow any other pressure damage to be occurred in other high-risk areas of the body. So, for example, with a patient who has a sacral pressure ulcer, they should avoid sitting upright in bed or in the chair as much as possible. But also, you may need to be mindful of developing pressure damage on the hips and shoulders if being repositioned from side to side. And sometimes, such in the case of uncategorizable pressure ulcers, the full depth of damage is not always apparent straight away. Debridement of some form can be a useful method for diagnosing the full extent of the pressure damage. And equally, pressure ulcers with devitalized tissue can be high risk of developing infections. And so removing this tissue rapidly may be beneficial to the patient in order to speed up their recovery. And larval therapy can actually be a safe, rapid, and effective option in many situations, including pressure ulcer management. And if larval therapy is the chosen form of debridement, there is the added antimicrobial benefits as the larvae ingest and break down microorganisms and biofilms in the wound, allowing granulation and proliferation to begin in a timely manner. And you might have heard that sometimes larval therapy is used as part of a wider clean it, close it care plan for treating pressure ulcers as well as other types of wounds. So in other words, the larvae are instigated to debride the damaged, devitalized tissue and prepare the wound bed prior to the application of something like topical negative pressure or grafting surgery. And without some form of effective debridement, these topical negative pressure or surgery options could be less effective. So let's have a little think about some tips, some things you might need to know so that you get the best out of larval therapy when using them with pressure ulcers, because it can be a little bit tricky sometimes. The first and most important step for ensuring successful outcomes with larvae is to ensure that the patient is fully aware of what is going to happen. So as part of a holistic assessment, discuss with the patient the procedure of application, management, and daily care, and make sure you gain verbal consent. With pressure ulcers in particular, it's important that patients understand that they will not be able to sit or lie on the area whilst the larvae are in place. And we do have patient leaflets that are available on our website or in hard copy if you require them or you think they might be useful when having those discussions. One of the most common causes of larval death is suffocation. And this could be either due to the patient sitting on them, or it could be the pressure relieving mattress conforming around the wound and blocking the oxygen supply. When using on sacral pressure ulcers, make sure to offload the pressure fully and avoid using waterproof pillows in the area of the wound as well. And it may be if you've got a mattress system where it's possible to deflate the cell under the area of the sacral wound, that might help to aid pressure relief during meal times if the patient is bedbound or needs to be on their back for a short period of time. Alternatively, if you do need to put the patient on their sacrum or sit up for a short period of time, you can remove the larvae and keep them in an aseptic field until they're ready to be reapplied. Always be wary of what secondary dressings you are using to hold the larvae in place as well. Dressings which wick or have gelling agents should be avoided, as well as film and or silicone-backed dressings. Ideally, the breathable cotton pad should be held with tape around the edge only, just to make sure that you hold it in place but don't block that airflow. And Inco sheets and incontinent pads should be used with caution, as these can also conform around the dressing and block oxygen flow as well. If your patient is incontinent, then you might need to consider alternative management options for the short time, such as convenes, flexi seals, catheters, just for that short duration that the larval therapy are in place. Now, the management of larvae on heel and foot pressure ulcers is very similar to sacral ulcers, but there are some key differences, some key points to be aware of. So it's important to avoid tight footwear, as these could squash or suffocate the larvae, and it's important to walk on them. Walking on them should be kept to an absolute minimum. Specialist offloading footwear such as Darko shoes may be helpful to ensure the patient does not walk on them, or alternatively the patient might be able to position their foot in a way which prevents them from applying pressure on that area whilst they're walking. You could even talk to podiatry. They may be able to assist by creating a soft cast for the affected area to help with that offloading as well. As with sacral ulcers, it's really important to offload the feet when in bed, but be wary of waterproof pillows again, and other offloading devices such as repose boots, which may conform around the wound and block the airflow. Similarly, if you've got a patient who's using a footstool when sat in the chair, you might need to consider if this will squash the larvae and discontinue using for the short period that they are in place. And again, if you've got mattress systems which allow for individual cells to be deflated, then this could help in reducing that risk of suffocation. And as we know, pressure ulcers can occur all over the body. So there may be a situation where you decide to use larvae on a pressure ulcer on somewhere other than the sacrum or the foot. And as with those types of wounds, it's still important to ensure correct dressings are used and that pressure is offloaded to ensure that the larvae are not squashed or suffocated. For deeper cavity pressure ulcers, be careful that exudate doesn't pool in the wound and drown the larvae. If the wound does have high levels of exudate, it's advisable to resolve this as much as possible prior to applying the larvae. You may also have to consider increasing the frequency of dressing changes whilst the larvae are on the wound. And be mindful that although pressure ulcers are often malodorous themselves, the exudate produced by the larvae is malodorous as well. So it's important to make sure the patient is fully aware that they may notice a change in the smell around their wound, but it's normal and nothing to worry about. The odour will improve with each dressing change, and it will go when the larvae are disposed of. It's very important to involve the patient in the planning process before the larvae are applied, because whilst it's possible for the patient to carry out most normal daily activities, bathing and showering the area should be avoided whilst the larvae are in place. Make sure that the patient is fully aware of what to expect for the full duration of the therapy, as this can have a huge impact on the efficacy of the larvae. And if patient is keen to remain as mobile as possible, then you might need to have some discussions with the wider MTT about how to do this. So now let's have a look at some evidence that we have supporting larval therapy with pressure ulcers. We have a lot of evidence to support the use of larvae in clinical practice in a variety of wounds, including pressure ulcers. Prompt debridement can not only make the wound easier to manage, but can improve the quality of life for a patient. And it's been proven that patients who have larvae are less likely to go on to have amputations when used on foot ulcers. There's also evidence to show that there is a 96% probability of debridement with a low risk of adverse events and infection. And larvae are proven to be antimicrobial with the ability to break down biofilms and antibiotic resistant bacteria. So you can be assured that using larvae in pressure ulcer management is evidence-based. So that's all our theory. Before I go on to case studies, we'll just have a look and see if there are any questions. I can't see any at the moment, but we have got a couple of case studies. So if you do want to type anything in, now's your time to do so whilst we're going through the case studies, and I will answer them at the end. So the first up case study that we've got is a foot pressure ulcer. And this is a 97-year-old lady. Aside from Alzheimer's, she had no significant medical history, and it's thought that this ulcer was caused by poorly fitting footwear. And as you can see, you can imagine it was very malodorous, and there was a high level of exudate coming from it. She had had sharp debridement in the past, but this, along with inconsistent use of other dressings, had meant that the wound had not improved. She was reviewed by the vascular team, who decided she wasn't fit for surgery. And it was also confirmed that the ulcer had Pseudomonas present, which was probably not helping with the malodor. So in this case, although it is a pressure ulcer, and you know, it would be nice to heal it. Healing the wound was not the primary objective. The team instead just wanted to reduce the malodor and exudate levels in order to make sure that it was easier to manage in her nursing home. So a biobag was applied to the ulcer in conjunction with sharp debridement, and it was confirmed after that that a second bag would need to be applied. But the team decided to soften the necrotic tissue first. So she had sharp debridement, biobag, hydrogel, biobag. And as you can see in this photo, after those two biobags, the wound is looking a lot cleaner. And it was noted there was significant improvement in the odor and exudate levels. And the team was also able to confirm osteomyelitis at this point, as had been suspected, and a more manageable dressing plan could be started. And you can see here the before and after. You can see how much healthier the actual surrounding skin looks as well, compared to the first wound, first picture, sorry, where the foot looks very red and swollen. And this is a great example of how larval therapy can be used for patients where the end goal isn't necessarily to heal a wound completely as well. So this lady's quality of life was still greatly improved, even though she still had an ulcer on her foot. And next up, we have got a heel pressure ulcer, and this is a category 4 pressure ulcer on a heel of an 86-year-old gentleman with type 2 diabetes and cardiac failure. He was admitted to hospital, and x-rays confirmed osteomyelitis. The wound did actually have a layer of hard necrosis, but this was softened using a hydrogel. And then after the hydrogel was on for about 3 days, a sharp debridement was done. I don't know how to phrase it better. Sharp debridement was done, and the necrosis was removed, and you can see it revealed this picture here with 50% thick fibrous slough and 50% superficial slough, and so the team agreed that maybe a biobag might be worth using to aid in lifting this. This is after the first biobag. You can see 3 days. Half of the wound has almost completely been debrided, but we're still left with some thick fibrous slough on the other half of the wound. So they decided to do 2 more bags of biobags, which were applied and managed. And you can see here, this on day 14, that the wound almost completely debrided. There were some small bone fragments which were manually removed with the last bag. And you can see that wound is looking a lot cleaner and starting to granulate. There's a little bit of bleeding, but that's normal and nothing to worry about. And here you can see the before and after. And you can see how the wound's clearly progressed really well in just 14 days. So that's almost it from me. Before I see what questions you've got, if you have any more questions after today, then you can always contact us on the clinical helpline or the help desk email, or we have a lot of information on our website as well, and there's quite a good patient side to our website as well if you want to use that. And if, like me, you're a little bit obsessed with social media, then you can come and follow us on any of your favourite platforms for the latest news, information, behind the scenes. We do other frequently asked questions. We've got case studies. So do come and hit follow on your favourite. So just let me sum that up for you. In conclusion, pressure ulcers have a significant impact on both the NHS and the patients with the ulcer. The first line treatment should always be prevention, but should a patient sustain a pressure ulcer, it should be debrided in a timely manner. Larval therapy is a safe, rapid and effective evidence-based option for debriding pressure ulcers in this timely manner, and can be part of an effective clean it, close it method when used in conjunction with treatments such as topical negative pressure or grafting surgery. There's evidence to show that larval therapy is cost effective due to the reduced nursing time required for managing the wound afterwards, as well as reduced need for analgesias and antibiotics. So thank you very much. I'm just going to have a look and see if we've got any questions. We've got a couple. So the first one we've got is, can you use on a heel ulcer with hard eschar? Well, you've seen I did have a case study there of a heel pressure ulcer which did have a hard eschar. I would also always check with your local policy. I do know that some trusts do have a policy where if you have an intact hard eschar on a heel, then it's they like it kept intact and left auto debride. But yes, it can be very beneficial depending on your local policy. The next question is, what happens if a biobag gets contaminated with feces when treating a sacral ulcer? That is a really good question, and it does happen from time to time. Personally, I would advise maybe giving it a clean with some saline. If it's really bad, then you might need to consider disposing. But yeah, it's really up to your local policy. What are the best products to use to protect the surrounding skin? So when you get the larvae, they're delivered with a small pot of pseudocreme, and we suggest using this one because basically it's the best one for standing up to the enzymes. Whilst the enzymes won't break down the healthy tissue, the surrounding tissue, there's a lot of fluid, there's a lot of exudate being created, and the enzymes can break down other barrier products very, very quickly. So that's why we put the pseudocreme in, and you can just make sure, if you put a border of that around the edge of the wound, and just make sure you check it every day, that will that there's enough there. That should protect the skin. If your patient's allergic to pseudocreme because of the zinc oxide or something like that, then an alternative could be to use whatever hydrocolloid is on your formulary, and create a physical border that way. The next question just says watering daily. So I always get a little bit edgy when I hear people use the word watering. Yes, they do need daily care. So if you come to one of our other webinars, or if you ever have teaching from me, I go through the daily care for them, but it does involve putting some saline moistened gauze on top of the biobag every day. You ideally shouldn't be putting more saline into the gauze that's already there, because you can't control how much saline you're putting in, and you could potentially drown the larvae. So it should be a fresh bit of saline moistened gauze daily. Someone else has put best secondary dressing, Premier Pour. I'm not entirely sure about Premier Pour, if that is suitable or not, if I'm honest. I know Premier Pad, I don't know if that's the same thing, is suitable, and I know Surgery Pads are suitable. Basically, you want a simple cotton pad. The simpler the better. Cheap and cheerful wins the day here. If you haven't got anything like that, then even just some more dry gauze over the top is best, but you really need to be avoiding your silicone dressings, your film dressings, anything that is super absorbent, and anything that has a wicking or a gelling action to it, because this could potentially block the oxygen flow to the larvae. So that's all the questions I've got so far. Now's your time if you've got any last minute questions to put them in. Otherwise, thank you very much for joining me today. I hope you've enjoyed it. If you do want to come and see any of our other webinars, we have got some more coming up over the next few weeks. If you go on to biomonde.com/BioMonde Live, then you'll see the information about all of our webinars upcoming. We've got a very exciting one with Dr. Yamini Nigam coming up soon. and we'll have more coming in the new year as well. I'm not seeing any more questions come in, so thank you very much for joining me today. Have a good evening, enjoy Stop the Pressure Day, and I'll see you all again very soon. Bye.